It is the most common sexual complaint men bring to a doctor. Almost nobody talks about it. Not erectile dysfunction. This one. Finishing far sooner than you or your partner want. And most of the shame around it comes from a myth about what is actually happening. This is premature ejaculation, and here is what the evidence actually says. No locker room advice. Just figures from the NHS, the DSM and sexual medicine research. So what actually counts as premature? Because occasionally finishing quickly is completely normal. The International Society for Sexual Medicine built its definition around 3 things, not 1. First, the time from penetration to ejaculation is consistently very short. Second, the man feels he has little or no control over when it happens. Third, and this is the key one, it causes real distress or frustration. All 3 matter. A short time alone, with no distress, is not a disorder. For lifelong cases, that time is usually under about 1 minute, nearly every time. For cases that develop later, it is often a drop to around 3 minutes or less. For context, one large 5-country study clocked a typical time of about 5.5 minutes. That figure ranged from under a minute to over 40 minutes. Wide is normal. Now, how common is it really? This is where men wildly overestimate how alone they are. Surveys have long called it the most common sexual problem in men. Depending on how it is measured, figures land somewhere around 1 in 5 to 1 in 3. The NHS simply calls it very common, and something that affects men of every age. So if this is you, you are sitting with tens of millions of other men. There are really 2 different versions, and telling them apart matters a lot. Lifelong premature ejaculation has been there from a man's very first sexual experiences. Acquired premature ejaculation shows up later, in someone who was previously fine. That distinction is not academic. The second type often points to a fixable cause. So why does it happen at all? The honest answer is that it is not simply willpower. A major player is a brain chemical called serotonin, which helps set ejaculation timing. Lower serotonin activity tends to shorten that timing. Higher activity tends to lengthen it. In lifelong cases, researchers have even linked this to variations in a serotonin gene. In other words, some men are wired from birth to ejaculate quickly. That is biology. Acquired cases lean more on other causes stacking on top of each other. Performance anxiety, stress, and relationship strain are common psychological drivers. Physical ones include prostate inflammation, thyroid problems, and erectile difficulties. Erectile dysfunction matters here. Rushing to finish before losing an erection trains speed. Which is why a clinician treats the 2 together, not one in isolation. That leads to the biggest myth. That premature ejaculation is about being inexperienced or weak. It is not a character flaw, and thinking it is only feeds the anxiety that worsens it. Anxiety speeds ejaculation. Ejaculating fast fuels more anxiety. The loop tightens itself. Breaking that loop, not white-knuckling through it, is what actually moves the needle. So what actually helps? Reassuringly, several approaches have real evidence behind them. The first are behavioural techniques that retrain the body to recognize the point of no return. In the stop-start method, stimulation pauses just before climax, then resumes once the urge fades. The squeeze technique does something similar, easing arousal back down before continuing. The NHS also points to strengthening the pelvic floor, the same muscles used to stop urine. None of these are instant. They are skills, and they take patient, regular practice. Then there are medical options, and here you genuinely need a clinician, not the internet. Certain antidepressants, the group called SSRIs, delay ejaculation as a side effect. Doctors use them off-label for exactly that, and one, duloxetine, was designed for on-demand use. That drug is licensed in much of Europe, though it was never approved in the United States. Topical numbing creams and sprays reduce sensation when applied shortly before sex. And where erectile dysfunction sits underneath, treating that can help the timing too. The point is not which product. It is matching the cause to the right approach. Combining techniques with medication tends to outperform either one used alone. One more piece the research keeps underlining. This is rarely a solo problem. Partners who treat it as a shared puzzle, not a personal failing, see far better results. Bringing a partner into the conversation, and the practice, lifts a lot of the pressure. So what should you take from all of this? A few clear things. 1. If it is consistent and it bothers you, it is worth raising with a professional. A GP or sexual health clinic has heard it many times and can help. 2. If it started recently, get the physical causes checked. Something may be treatable. 3. It responds to treatment. This is one of the more fixable sexual health problems. And a reminder. This is general education, not medical advice, and I am not your doctor. Any medication or treatment decision belongs with a clinician who knows your history. Every figure here is sourced in the description below. Go and check it yourself. Follow for evidence-based health, explained. A new video every day.